I'd now like to bring in the Essex team. So that's Adrian Coggins and Richard Comerford. This is a very ambitious model which includes a range of providers working together, including specialist community health services. So it's a very innovative and ambitious model. So Adrian and Richard, over to you.
Good morning. Hopefully you can hear me. Good morning, Lord Farmer, Samantha, Andrew, and thank you, Rachel, for handling the slides today. My name's Richard Comerford. I'm the Managing Director for Essex Child and Family Wellbeing Service, and I'm joined by Adrian Coggins, who's the Head of Wellbeing and Public Health Commissioning for Essex County Council. I'm going to begin the presentation, and Adrian will come in at the back end. Just a slight warning to you all, there's quite a lot of, a number of slides here and a lot of detail, so some of the slides will be skipped over, but please feel free to contact me if you've got any questions. My details are at the end of the slide pack that will be shared with you. Thank you, Rachel. I won't go into the detail here, but the last strapline or motto that we apply sums us up, and it's a little bit Kennedy-esque, but it's this: striving to improve health and wellbeing outcomes for children and families in the community, for the community, and with the community. It's a motto that we hold dear in Essex Child and Family Wellbeing Service, and it sums up what we're about. Next slide, please, Rachel. The model that we're delivering as Essex Child and Family Wellbeing Service is unique, as Andrew's alluded to, in that it's co-commissioned by Essex County Council and West Essex CCG. And in fact, the bit that Essex County Council commission is also unique in that they've commissioned integrated public health nursing from their Healthy Child program alongside the early help offer that is the traditional children's centre offer. That in itself is unique. But then if you throw in West Essex, the children's community health provision, and in that it's paediatrics, speech and language therapy, children's nursing, all sorts of other therapies and so on, it makes it a particularly unique model. And it starts with the commissioners coming together with a clear vision. If I could just take a step back, Rachel, sorry. As you can see from this illustration, VirginCare is delivering this contract in partnership with Bernardo. So we are the primary providers and we have a clear mandate in what we need to deliver. But we also have a number of subcontracted providers, and it's clear within our contracts with those subcontracted providers that we're all working to the same aims and the same goals, and aiming to achieve the same outcomes as set by the co-commissioners. Equally, as we work in partnership with multiple agencies that work with our service, both in our family hubs and the communities, it's important that we emphasise that we are working towards these clear outcome measures. So the outcome measures are owned and shared by all parties, those that are directly commissioned from this contract and those that we interface with that are serving to benefit the greater good. Next slide, please, Rachel. There's a little bit of detail here about the contract, but it's a large contract, and Essex itself has a population of just over 1.5 million people, and it's a big geographical area. There are 38 what were children's centres, if you like, 38 family hubs. Of those 38, there are 12 distinct family hubs, one per district. So the other 26 are spoke model, if you like, outreach delivery sites. So they are traditional children's centres in a sense, but they are the smaller outreach versions. So that each district has its own large family hub. And I liked Samantha's comment earlier that, you know, family hubs are essentially an estate, they're a building, but the offer that's delivered from them it transcends the building and goes into the community, and it's a service without walls. So that's a particularly important point for areas in urban and rural communities where you've got outer urban and rural communities where there's big distances between family hubs and delivery sites. So a lot of the work that we outreach deliver is in community halls and church halls and so on. So it's important to recognise that not like inner cities where everyone can access a site, we have to understand that we do need to have a service without walls. moving on to the next slide, you can see from this illustration the size of Essex and the number of the different colours represent the different districts. So each of those districts has one large single family hub that is the centre of that district. And as I say, out from there, there are outreach delivery sites. And before I go on, it's another important point to recognise that across this large county, there are 5 clinical commissioning groups and now 3 STPs. And by that very nature, it brings complexity in joint working and strategising when it comes to children's services. At the moment, we have the challenge of trying to not only communicate with the 3 STPs and the CCGs within them, but the other local authorities that link with those STPs. So in the north, it's Suffolk, and in the west, it's Hertfordshire. So it adds more complexity in trying to achieve the goals for your local people, a local population at a community level. The next slide, please, Rachel. This illustration is the illustration of our model. On the left, you can see the green symbol is the family hub, and it's connected to the district, and there is the governance structure that sits above it, both by the local authority as the primary commissioner, and ourselves as a service provider. The service on the right, the illustration on the right, just demonstrates where we place children and families at the centre of what we do, local communities and neighbourhoods around that. And we service, like GP primary care networks do now, we try to service the same secondary schools, feeder primary schools and communities, and work in partnership with local agencies. Next slide, please, Rachel. This illustration is of our workforce and how we work across the pre-birth to 19 age range, including up to 24 for young people with SEND. Along the top, you can see unique roles that we've introduced, and things like volunteer coordinator, healthy schools engagement workers, community engagement workers that aim to bring in our, both to outreach into our communities, but also in reach, in bringing partners into our service model. And build the relationships and partnerships that we need. We can just go to the next slide. This illustration is really aimed at our health partners who may be on this call. What we are trying to illustrate here is historically public health nursing and children's centre provision and health provision has worked, as we heard earlier, in silos. And often the activities of children's centres have been either overlooked or undervalued. And what we see historically is a huge sort of cyclical movement of patients between GP practices and acute hospitals. And I think, as Samantha said in her presentation, we have a huge role in early help and prevention. And if our model, if we can move to the next slide, Rachel, shows that if we not only just co-locating organisations and staff, but if we also conceptually bring together with the same people together with the same aims and ambitions, we can consume our own smoke, we can build resilience in communities, upskill communities to look after themselves, and prevent a lot of long-term problems, both health and social care problems that in this illustration should reduce dependency on healthcare, on hospital care, but also in local authorities produce dependency on social support through either housing benefits and various other dependencies. So at this point,
Richard, sorry to interrupt. You got 2 minutes. Thank you.
I'd like to hand over to Adrian now, just to talk a little bit about how the early years review led to this model and how the partnership element was introduced. Thanks, Adrian.
Thank you, Richard. So cramming this into 2 minutes, but we can obviously discuss more in the panel, hopefully. So lots done, lots still to do. We've joined up previous children's centres, early years activity with Healthy Child Programme activities, and Richard and colleagues have built a fantastic integrated workforce from those previous services. The next steps, if we're serious about outcomes, is working with other parts of the system to commit to the same outcomes and define what their contribution is in a coordinated approach which has to transcend organisational boundaries or specific contractual requirements. I think Simon from Isle of Wight spoke about a mindset, and that's how we achieve it in a nutshell. So family hubs give us an opportunity to physically manifest joint working towards shared outcomes. It's not just co-location, although that's a useful part of it. It's not about changing physical use of a building, and it's certainly not just about reconfiguring organisational boundaries. It's got to be a response to a cultural mindset of absolute commitment to bringing all parts of the system together to achieve the same outcomes and identify their unique contribution to that outcome. So next steps are to, I think, embrace the broader determinants of health model, critical to underpinning good well-being, and to manifest that locally. So in addition to, for example, messy play and traditional activities, of which I'm a great fan, we need to introduce activities that Doncaster and Isle of Wight have previously spoken around, such as working with the DWP, for example. But we've got to mainstream that. And we should look at things like the work of the Robert Wood Johnson Foundation, which shows us that 30 to 40% of determinants of well-being are socio and economic. So this is not just an add-on, this is a core part of how we achieve the outcomes if we're serious about achieving those outcomes. So family hubs are a continuum of possibilities, from a narrow program of activities through to that broad program which covers the wider determinants of health. And we need to recognise the inescapable data set, Michael Marmot, Carol Black review, that shows what the true determinants of well-being are. And family hubs is an opportunity to focus on those in a well-defined geographical area with a well-defined broader join-up of different activities. So it's the hub, isn't it? The clue's in the title. The family hub is the centre of our effort. So we need to radiate broader, more inclusive circles out from this, which include a broader range of stakeholders and can operate across a wider range of life domains. I think it's not just words and philosophy and vagueness. We need crystal clarity and forensic analysis on, firstly, the problem definition. What is the problem we're trying to address? And I don't think we do that anywhere near well enough collectively. And then secondly, a robust process to generate both well-defined shared outcomes and well-defined proxy measures and milestones towards those outcomes. And I would say we need a lot more national discussion on these, because some of the measures that we've got around some of the activities that we are delivering, they will not give us a close enough indication of how we are doing towards achieving some of those longer term outcomes. So whatever we do, we need to spread bet more on the diversity of activities we do, and family hubs are an opportunity to do that, again, in a well-coordinated, defined geographical area. So we need national debate, I would say, on how we convert family hub activities into a broader programme of work, which gives us a more assurance of a stronger link between some of the short-term activities that we're undertaking and some of the longer-term outcomes. And I'll just finish by throwing in what I think was the most important thing I learned in my public health masters, where somebody once said to me, make the important measurable, not the measurable important. It's much harder, but it's necessary. Thank you.